Hello everyone, distinguished guests, colleagues, ladies and gentlemen, welcome to the FIP series on transforming vaccination globally and regionally. Thanks to those who are joining us live today and also to you who are listening in afterwards. I'd also like to warmly welcome our guest today, who I'll shortly introduce. For those of you who don't know me, my name is Catherine Duggan. I am the Chief Executive Officer here at the International Pharmaceutical Federation, FIP. My job is to ensure the strategic delivery of the objectives, mission and vision agreed by the FIP Council, our members, on behalf of patients and the public we serve. FIP's vision is a world where everyone benefits from access to safe, effective, quality and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences and education. We're so pleased to be delivering this event, the 6th of Series 2, entitled Pharmacists Vaccinators as a Way to Improve Access to Medicines, the FIP Development Goal 18, Access to Medicines and Services. Next slide, please. Before we get going, I thought I'd just mention some housekeeping announcements. This webinar is being recorded and live streamed via Facebook. The recording will be freely available on our website at www.fip.org. We'd really welcome you asking us questions using the question and answer box, and we'll come to those at the end of the session after our two speakers have spoken. And you're also welcome to provide us with feedback at www.fip.org/membership registration. Next slide, thank you. So I mentioned I'm Catherine Duggan. I'm the Chief Executive of FIP. Our federation comprises more than 150 nationally based member organisations, 170 academic institutions, and our science member organisations. And we represent around 4 million individual pharmacists. At FIP, we know we cannot achieve our vision by working alone, so we seek to work across global organisations such as the WHO and United Nations, the World Health Professions Alliance, and other international professional groups. The International Federation on Aging is one of those groups, and we're delighted to have Jane Barratt here today. I will introduce Jane in a few moments. Next slide. Transforming vaccination regionally and globally is the first of our transformation outcome-based online programs of its kind, and it's underpinned by the FIP Development Goals that we launched on the 21st of September this year. The final outcome of the programme will be a historical global commitment to action on vaccination and pharmacy. And we would offer you all the opportunity to listen to the series to date. We will also be publishing a Transforming Vaccination collection early in 2021. Next slide. So this series began in September. Episode 1 was on World Pharmacist Day, the 25th, and we aim to run through to the middle of December. It's quite a packed programme, with Series 1 focusing on identifying the needs of pharmacists and the pharmaceutical scientist workforce to deliver vaccination transformation. Series 2, which is where we are at the moment, we are discussing the actions required to deliver the needs identified in Series 1, but align these to the development goals, giving us a 10-year programme of transformation. The next series will focus on the FIP member organisations across the 6 WHO regions and how they have addressed, or possibly more importantly, will address these actions to deliver our commitment. Next slide. Today we urge you all to engage with us and help us answer those questions. Please type your answers in the chat box to these questions you see on the screen, and also ask us any questions that you want, and we'll see if we can get through them at the end. But in your opinion, what single factor should be prioritised to transform pharmacy vaccination services globally and regionally? And then for you, what would be the most important achievement in terms of pharmacy vaccination services in your country in the next 5 years? Next slide, please. So now we move on to today's episode, which is Pharmacist Vaccinators as a Way to Improve Access to Medicines. It's an interview format that focuses on the FIP Development Goal number 18, which is access to medicines and services, from the perspective of the pharmacist, as well as FIP Development Goal number 10, equality and equity. Now, we all know that the role of pharmacists in ensuring vaccinations are widely and easily accessible by all people in all areas of the world, and the expertise of pharmacists in delivering the logistics and services need to increase if we're going to achieve the vaccination rates we need. Among many others, the main outcome for today is to understand the impact of the development goals that we've mentioned, goal number 18 and goal number 10, to make sure we can deliver. Next slide, please. Before I hand over to our first speaker, I'd just like to welcome Dr. Jane Barratt to all of you today. She is the Secretary General of the International Federation on Aging, the IFA, an international non-governmental organisation with general consultative status with the United Nations and its agencies, including formal relations with the WHO. Representing over 75 million older people through the membership of the IFA, Jane has direct responsibility for the corporation's global operational performance, including the leadership at the UN and the WHO. Among her many current positions, Jane is the member of the Vision Academy, member of the Global Agenda Council, World Economic Forum, Director of Crest Healthcare Sciences, and Chair of the Education Advisory Committee, as well as being an associate scientist at the Sinai Health System. Her availability and involvement is widespread and just a testament to her skills and capability. Today, Jane is speaking to us entitled Public Health Messages as Levers to End Immunisation Inequity. Jane, we are delighted to have you here. Over to you. Jane, I think you're still muted.
You know, you do think that I would have got used to this by now. My apologies. What I was saying, Catherine, is thank you very much for the opportunity to be with you and your colleagues today around the world. And most importantly, thank you for the partnership that the IFA has with FIP. You know, we have had an increasing cooperation, collaboration, and now strong partnerships in many different areas. So I thank you for that. As I move into my presentation, I just wanted to also acknowledge, and it is very important that we pause every time that we're on a Zoom call and acknowledge the reason why we're here. Because today, 55.1 million people have been diagnosed with coronavirus. Of those, 35.4, in addition, 35.4 million people have recovered from COVID. However, there are also 1.3 million people who have died of COVID. And while we grieve the loss of those 1.3 million people, we also need to acknowledge the many millions of families and friends and kin and colleagues who have not been able to be with that person who has been dying from COVID. You know, in this fast world that we live in, and we do live in a very fast world, you know, with Zoom to Zoom to Zoom, you know, we don't even have the time to pause and stand still. And I urge all of us to stand still for a moment today, because in standing still, we have the opportunity of reaching across the aisle to different sectors and different disciplines to improve a common agenda in our work and in this pandemic. I also want to acknowledge the many pharmacists who are working on the front line as we speak. And as I mentioned to Catherine, you know, I'm very entitled. I am working in my apartment. I have all of the mod cons that I need. You know, when and if I go out, you know, I'm well protected, you know, but many of your colleagues today are working on the front lines. And it's those pharmacists that we go to because they are trusted professionals. You know, they sometimes have the time to talk with us about, you know, symptomatology and diagnosis and medication. And that's where I want to start the conversation today, thanking pharmacists and pharmacies all over the world, many who are working really in frontline situations, but in dire circumstances. So I want to acknowledge that. Next slide, please, Farah. You know, when we think about the role of pharmacists, I think about a life course approach, because you are the trusted professional from the time that, you know, a baby's born all the way through to when we die. And, you know, this image is taken from the first ever world-based evidence-based world report on aging and health from the WHO. It is a defining document because it really sets out the future of the way we will be thinking and acting around age and aging and health. You know, what we do know is that our functional capacity and our intrinsic capacity, you know, are fairly high, you know, when we're born. But we do make decisions as we go through life about our lifestyle, you know, exercise, you know, alcohol, smoking, lifestyle habits, good food. You know, we make decisions that impact our health and well-being. We also need to consider that across the life course, there are opportunities to maintain and improve our functional ability, and that is through regular exercise, etc. But there is something different, something more that we need to consider, and that's the environment. WHO have really expressed in very clear terms, you know, that to create an enabling environment so that people of all ages, but particularly older people, have reason to value. So in the environment, how can we make it enabling for conversations, for communications, for access, for education? And at the heart of that, is it equitable? You know, many older people are really struggling at the moment, and when they go and speak to a pharmacist, because the pharmacist may have on a mask, the older person has on a mask. So communication is very different than what it was 12 months ago. You know, and these small tips and tricks about how do we communicate more effectively, you know, have really been exposed in the time of this pandemic. As we move into the final trajectory of our life, we often call it the third phase. And in this third phase, you know, there are often three different elements. You know, we know people, older people, who are independent, autonomous. We also know people who require some assistance to maintain their autonomy and live in the community. And then there is a third group that require much services, many levels of assistance, and maybe in residential care. You know, I would argue today that one of the most important public health interventions of our time, vaccination, you know, is one of those interventions that can not only help improve our intrinsic capacity, but will improve our functional ability. Pharmacists are an important vaccinator gateway to ensure older people and those most at risk, you know, can fulfill that decision to be vaccinated. And vaccinated, you know, pre-COVID times, you know, against common yet serious and life-threatening and life-altering infectious diseases, including influenza, pneumococcal pneumonia, pertussis, and shingles. So we need to keep reminding ourselves that some of the barriers that I'm going to be talking about were very much with us pre-COVID. You know, I saw that the title of this series was Transforming Vaccination Globally and Regionally, and I fully endorse that. But I'm speaking to those pharmacists today that are in country, in their local community, because being at the front line, we need to understand what are the intrinsic barriers in your local community that are preventing or not enabling you to conduct your work to ensure people of all ages, but older people, to maximise the opportunity to be vaccinated. Thank you, Farah. So when we move on to thinking about equity and inequity, we also want to be sure about what we're talking about. You know, equality is that there is enough to go around. But health equity is a matter of life and death. And that's been certainly borne out, in the brutal results of the COVID pandemic. In many countries of the world, we've seen that the poorest of the poor are paying the highest price in this pandemic. Those essential workers that work in long-term care, that work in supermarkets, that work in other essential services, many that are low-paid jobs, they are at highest risk in many circumstances in many local communities. And much is the same when we consider influenza pandemics. And so what is the role of the pharmacist in reducing inequity and being part of a program that ends immunisation inequity? Thank you, Farah. So equity is reached when everyone has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this position because of their position or socially determined circumstance. Now, we know that health literacy, education, where we've been born, where we grow up, access to health services, access to treatment, they all are barriers to achieving equity. But when we look at health policies and practices, equity seems to be the lofty ideal. And in fact, it should be the frontline argument for reorientation of health and social care systems to ensure, a healthy percentage of GDP is invested in health promotion and prevention practices. And that's not the case now. What EFA is very concerned about is the austerity measures that will likely come into play in many countries of the world. We cannot allow a reduction in vaccination gateways, vaccination schedules, vaccines for people of all ages. We must protect the progress that has been made and must stand together in going forward for change, positive change. Thank you, Farah. Now we move on to just a glimpse into a study that the IFA has just completed, and it's called Changing the Conversation on Adult Vaccination. We studied 10 countries. We examined and analysed public health messages from the governmental website, but also patient and ageing organisations. We wanted to look at the content. We wanted to look at the channels, the pipelines, and we analysed, the message. Who was it directed to? Was there a threat in the message? Was it received in a way that a person could actually make a decision? Thank you, Farah. And again and again, Farah. That's it, perfect. No, back again. That's lovely, thank you. So in this image, you can see that across the top, there's the symbols of the flags of 10 countries. The green indicates well developed, the orange indicates partially developed, and the red indicates not yet developed, or there is a lack of evidence. Now, I've highlighted 3 particular boxes where many countries did not do well, in the analysis. So the first one was clear communication strategy. And we can see that many countries did not have published context-specific communication. That's important when someone has an underlying condition such as cardiovascular disease or diabetes. They need specific information, so that they can recognise that this is for them. The second is interactive communication. Once again, many countries failed to have a mechanism of interactive communication. And thirdly, realistic timelines. There were several in the red boxes, including the United Kingdom, Brazil, that did not do well in scheduling sensitive awareness campaigns. Now, you may wonder why I'm sharing this today. The very reason is because pharmacies and pharmacists are really a gateway where messages are going to be critical. So I encourage FIP and pharmacists around the world to actually investigate, analyse the kind of communication that you're conducting with the consumers, but also the messages that you are promoting around not only COVAX, the vaccine that will be with us, in the coming months, but vaccines that you have the ability to administer now. So in many countries, shingles, influenza, and pneumonia. What are the messages that you are conveying, and what responsibility do you have? What struck me when I was reflecting on this presentation this morning is that we didn't study messages from pharmacists, and I wonder why. I mean, I need to learn as to whether this is an area that pharmacists are interested, concerned with, and are working. As frontline communicators, it is critically important that the messages that you deliver and convey in different channels, whether it's a stamp on the package that you put the medication in, or whether it's signs, that they actually speak to the individual. This study showed without a doubt that we have assumed that everybody has the same level of health literacy, and that's just not the case. It's not good enough for governments to say it's flu season, go and get your flu vaccine, because we are not reaching those who are unreachable. We are not reaching those most at risk of vaccine preventable diseases. And with that, the life-altering consequences of someone who may be the only person in the family employed, being having to take time off work and losing their job. So pharmacists have a profound responsibility as part of a team. Next, please. And my next comment really speaks to, the developmental goals, FIP 10 and FIP 18. We talk about equity and equality in workforce. And I think some of what I've said today, needs to be reflected in those workforce issues. But also I call on FIP, to actually be part of the conversation to create changes in public health messages, because you are an important professional organisation, and it's very important that you collaborate with one another, but it's equally important that you are seen to be leading in the conversation and partnerships across sectors and across disciplines, because we all have to work in a common agenda towards a common goal. From the analysis of those public health messages, the IFA put together an effective communication framework, and that starts with a comprehensive adult vaccination program. We have also done a lot of work in how do we find the information about vaccine schedules, and that's something that pharmacists could take an important role in. Are pharmacists on the National Immunisation Technical Group, for example? Why not? How? It's those strategic conversations that need to be happening now and going through the future. Some of the other aspects of the framework is different messages for different audiences. So for someone that has diabetes, they need to receive a message that makes sense to them. Why is that person more at risk of the coronavirus or pneumococcal pneumonia versus someone who is not? The disaggregation of messages and language is critically important, but we don't do that well generally. In terms of multiple tools and channels, there is a great example in Brazil that has something called D-Day, and that's the day that millions of people are immunised against influenza. 43 million people are immunised, have been immunised in 2019 on D-Day. And that day represents a time where families come together and are immunised. There are not too many D-days around the world. Regular updates of information. And while we live in this fast-changing world of virtual meetings and technology, keeping websites up to date is not happening. And also, information is firmly embedded in the heart of a website and very difficult to find. And so once again, the pharmacists have a unique opportunity to be not only, a legitimate voice and strong partner in a common agenda for vaccination globally, regionally, country and locally. You have a responsibility, as EFA does, in ensuring that there are regular updates of information. And finally, engagement and support of multiple stakeholders. IFA's responsibility is to reach across the aisle to different partners, to different disciplines, to different sectors. There is little point of an ageing organisation to speak to geriatricians. We need to be speaking to public health professionals, diabetes organisations, lung organisations, ageing organisations, and also pharmacists. So it's about the interconnected approach towards messaging and strategic opportunities for change. Next, please. And finally, I wanted to pull the FIP developmental goals, back into 3 very important frameworks that IFA pins our work on vaccination on. First of all, the Decade of Healthy Ageing, which will be launched next year. And we are moving towards the opportunity that this will be called the United Nations Decade of Healthy Ageing. There are 4 key action areas: the way we think, feel and act about age and ageing, which is age, long-term care, primary integrated care, and age-friendly cities and communities. And each of those action areas, I could put the lens of adult vaccination over. Also, the immunisation strategy, Agenda 2030. There's a connection between the decade and the immunisation agenda. And finally, the link goes to the UN Sustainable Development Goals. Could I suggest, that the FIP developmental goals are also embedded and threaded through those important WHO frameworks and goals. And in closing, once again, I thank the pharmacists and pharmacies who are on the front line, and thank you for the opportunity of being with you today. And I look forward to questions and opportunities to discuss my thoughts and build a stronger network around the world. Thank you very much, Catherine, and thank you to Farah for moving my slides.
Thank you so much, Jane. A lot to chew over there. We look forward to seeing the emerging Q's and A's. But I have to say the embedding concept is front and centre in our minds about how we get these development goals of our organisation embedded in the profession is one thing, but how do we get them relevant and in other organisations' mindsets is another. We will be working with you to help us with that. We know that, Jane. Lovely. Thanks so much, Jane. A really important presentation, colleagues who are on the line listening. I know you will all agree. Thank you so much. So now I'm going to say a couple of words of welcome about our second speaker. Our second speaker today is Alexandra Roos, known as Ali. And Ali Roos is a PhD student in bioethics and health policy, the Department of Health, Policy and Management at the Johns Hopkins Bloomberg School of Public Health in the USA. Ali's research interests include infectious disease ethics and policy, ethics of public health screening programs, food and nutrition policy, and vaccine policy. Really interesting for our discussions today. Previously, Ali was a senior research assistant at the International Food Policy Research Institute, but today Ali is going to present us with some thoughts and some thought-provoking ideas around vaccine equity in the US. Over to you, Ali.
Thank you very much. It's great to be here today. And I want to, just add a little bit to that lovely introduction and say that my current research focuses on pharmacy vaccination of older adults in the US, particularly focusing on the shingles and high-dose flu vaccines, and including work on the ethical dimensions of vaccination and aging. And I think there's a lot of room for expansion in bioethics, reaching out to pharmacists, and fostering some collaborations there. So I'm quite happy to be here today addressing you. So I want to begin by sort of echoing what Jane said about equity versus equality with a brief summary of equity and equality, because these are not only important concepts generally in vaccine ethics and policy, but they're also particularly relevant right now in the COVID context. So in the US, we see enormous disparities in COVID infections and deaths in certain communities. This includes older adults as well as Black and Latino adults in the US who've been disproportionately impacted. So this will be quite a concern when we finally do have a COVID vaccine ready for rollout and making sure that it reaches the populations with the highest need. So equality is providing everyone with equal access to the same type of health service regardless of need. So you can see in the left figure under equality, everyone has been provided with the same box to stand on to view the game. But equity gets at actual outcomes in different groups. So it may be, and in fact is often the case, that marginalized groups require additional resources and attention to address underlying causes of health disparities. So this may actually mean delivering different services to different groups. So you can see there are two boxes stacked up in the equity illustration to ensure that everyone can view the game. So it's a nice little visual. Next, I'll be talking about some vaccine disparities in the US that are troubling from an equity perspective. And I'll talk about the role that pharmacist vaccinators can and do play in promoting vaccine equity. And I'll be speaking regionally about the US context in this presentation, but I do hope that many of the takeaways may still resonate for programs in countries elsewhere. So current challenges in vaccine equity in the US, Black, Hispanic, and Asian adults in the US have lower vaccine coverage rates than white Americans for all adult vaccines. And this maps onto larger patterns that we see of health disparities in the US. Adolescents in rural parts of the US are less likely to receive a first dose of the HPV and meningococcal vaccines than adolescents in urban areas. And I should note here that there are also disparities in cervical cancer outcomes between urban and rural adults. So here, this difference is especially troubling from an equity perspective because we have not only different vaccine uptake rates, but we also see farther down the line very different disease outcomes, suggesting that there really is a need to target this higher need population. Uninsured Americans, so as you know, we have very complex patchwork of health insurances in the United States, and uninsured Americans have worse access to preventive measures that can be used to detect and treat vaccine preventable diseases, as well as lower rates of vaccine uptake in general. So this is also concerning from an equity perspective because there may be payment and cost issues. And it's important to note that there are a lot of different contributors to these types of vaccine disparities. And I'll speak broadly about a few factors right now that contribute to vaccine disparities. So one is access. And the relevant question for access is, are there sufficient and acceptable access points where a person can be vaccinated? From an equity perspective, this is where pharmacies play a huge role. There are many areas in the US that have low densities of primary care providers, particularly rural areas in the US. So pharmacies are a critical extension of vaccine services in those areas. Another barrier is cost. So the relevant question there is, have cost barriers been minimized so that the high need subgroups can afford vaccinations? In the US, one equity promoting program we have to address cost is the Vaccines for Children program, which ensures free access to all required childhood vaccines for children. There are some implementation issues that remain with the VFC program in pharmacies, which I think is an interesting policy barrier to be addressed. But pharmacies play a critical role in addressing cost barriers because they provide a means of obtaining a vaccine without having to pay for a primary care appointment. So that's a really important role that pharmacies play. And finally, in the US, trust is a major driver of lower rates of vaccine uptake in certain communities. This manifests in many different forms, ranging from parental fears about childhood vaccines to community level fears in Black and Latino communities in the US about the safety of vaccines, given the history of medical abuses inflicted on those communities. So it's very important for the public health community to take seriously concerns that different communities may have, and find ways of earning and maintaining trust. And this has contributed to persistent and long-standing low rates of uptake. And that is an area where pharmacist advocacy and patient advocacy about vaccines plays a really critical and important role that I'll talk about a little bit more later. Next slide, please. There are many advantages of pharmacy vaccination in the US in promoting equity, and especially from an access perspective. So Americans, particularly older American adults who have many chronic conditions, who may be at higher risk for infectious diseases, have very frequent contacts with pharmacies compared to other healthcare sites. One study found that pharmacy contacts are very frequent among Medicare beneficiaries. So for anyone who doesn't know, that's the insurance program we have that covers older adults because they have more chronic conditions, they may have more medications, and they're a key population for immunization. They have a lot of pharmacy contacts. More than 90% of Americans live within 2 miles of a community pharmacy. And as I mentioned before, there may be lower densities of primary care practices for Americans living in certain areas. So these are just a really important extension of immunization services in those areas. Pharmacies also have more evening and weekend hours than primary care practices in the US, which is a really important feature that makes them useful sites for immunization here. One study of adults who were vaccinated over a 1-year period at Walgreens found that the largest proportion of those adults utilized evening, weekend, and holiday hours at pharmacies. And these tended to be younger, working age, healthy adults because, of course, it's easier to go in the evening to the pharmacy than it is to leave work in the middle of the day and go to your primary care practice. So that's a great extension of services that pharmacies provide for vaccination. And finally, pharmacist immunizers have very specific and extensive experience with maintaining complex cold chains and unique storage requirements that will be especially critical in the future for successful rollout of a COVID vaccine, given that we think there will probably be intensive freezing requirements for that vaccine. Next slide, please. So here in bioethics, we use case discussions a lot to highlight different equity and public health ethics issues. So here I have 3 potential cases for discussion, and each of these pertains to a different vaccine and highlights a particular high need subpopulation that may have different or additional needs for vaccination. And for each of these, I have written up summaries of factors that drive, number 1, drive disease disparities or vaccine disparities for the subpopulation of interest, as well as ways that pharmacies promote vaccine equity for these subgroups, and areas that may require additional resources and attention to further expand this role and promote equity. In the interest of time, I will be discussing cases 1 and 3 for today, but I'm very happy to discuss case 2 since it's quite of interest to me later on. So case 1 is HPV vaccination for adolescents in rural areas, which I mentioned before. So some of the reasons for disparities between urban and rural adolescents, girls are less likely in rural areas to complete the HPV vaccine series, and boys in rural areas are less likely to both initiate and be up to date on HPV vaccination. There are many factors that contribute to these disparities. One, as I mentioned, is that there are fewer pediatric primary care providers in rural areas. There's a lower density of pediatric practices. One is that there may be more reluctant attitudes of parents and providers in rural areas to vaccinate children against a sexually transmissible disease, which is why the CDC here in the US has provided messaging recommendations that it be discussed as a cancer prevention vaccine, which it is, for messaging purposes, which is something that can also trickle down to pharmacy messaging. The HPV vaccine also requires multiple follow-ups, so it's not just initiation of the series, it's follow-up as well. Cost is sometimes also a prohibitive factor. There's been some really interesting work on the acceptability of pharmacies as HPV vaccination sites in rural areas. This is generally very acceptable to parents, especially it's a big perk that children can be taken outside of school hours. That has actually come up in qualitative interviews, that children don't have to miss school if they get vaccinated at a pharmacy against HPV. But there are some issues that remain to be addressed that would actually help pharmacists play a greater role in promoting equity through HPV vaccination. One is to improve communication between primary care providers and pharmacists. So primary care providers in many states in the US actually have to submit a standing order for the HPV vaccine. And in some states, there are actually age limits on how old a child has to be to receive an HPV vaccine at the pharmacy. So there are a number of policy and legislative barriers that are really important for this agenda to make things easier for pharmacists in playing this role. And pharmacists can also take an active role in patient advocacy, education, and making patient recommendations for this vaccine. So next, I'll discuss case 3, which is influenza vaccination of older adults and Black and Hispanic adults. And I've chosen to focus on these two subgroups because these are both relatively high need populations for the influenza vaccine, but the needs are quite different, which is what I want to highlight here. And I think there are different roles that pharmacists play and different ways that these roles can be expanded for these different subgroups. So as many of you know, older adults bear a disproportionate burden of hospitalizations and deaths from influenza. However, interestingly, rates of vaccination are actually relatively high for older adults compared to younger adults. They could be higher. They're around 70% in the US. And this is a group highly motivated to be vaccinated compared to other age groups, but they are inherently more susceptible to influenza infection, as well as more serious sequelae because of aging immune systems. And there is a high-dose flu vaccine designed to address this and generate a stronger response. And that's sort of increasing uptake in the US of that vaccine. Black and Hispanic adults in the US also have very high burdens of influenza morbidity and mortality. However, rates of vaccination are relatively low in this population compared to white adults. And this is an area of health disparities that is very much of interest right now. And is receiving a lot more attention, especially in light of COVID. Comparatively lower uptake and acceptance of vaccines in this subgroup suggests that there are different and additional measures that should be taken to promote uptake that focus specifically on earning and maintaining trust. So what role do pharmacies currently play in promoting equity for these subpopulations for this vaccine? So for older adults, pharmacies are very acceptable sites for vaccination. Older adults have very frequent contacts with pharmacies, and actually that subgroup is the one that utilizes pharmacies and retail clinics at the highest rate for influenza vaccination. It's a widely acceptable site. Evidence indicates that this is somewhat less true for Black and Hispanic adults, and there's been some really interesting qualitative research in recent years on this and sort of figuring out why that is. Some of that has to do with the fact that some pharmacies in cities in particular may have higher densities in wealthier areas. And so one thing that could be helpful is to improve outreach and just improve community utilization of pharmacies for this subpopulation. So issues that remain to be addressed for older adults include ensuring adequate supply of the high-dose influenza vaccine and other vaccines tailored to the immunological needs of older adults, since we do have some spot shortages here of the high-dose influenza vaccine for older adults. That's one of the things I'm actually studying right now. So ensuring supply and keeping up patient advocacy and communication for older adults is critical. For Black and Hispanic patient populations, we have to make sure that patient advocacy and education is culturally competent and addresses specific sources of vaccine mistrust. So Sandra Krauss-Quinn is a researcher in the US who has spent her entire career focusing on this particular vaccine disparity between white adults and minority populations for influenza vaccination. And fear or worry about side effects is very, very commonly mentioned as a concern for racial and ethnic minorities for influenza vaccination. So it's really important to tailor vaccine advocacy, vaccine communication to address those specific worries and concerns. The CDC has extensive guidance on how to provide strong recommendations for primary care providers. And this is an area where for the immunization neighborhood, that includes pharmacists as well as primary care providers, there can probably be even more collaboration to ensure that that messaging is being applied in all contexts. Next slide, please. So in conclusion, this is just a few resources and interventions that are needed to expand pharmacy's role in promoting vaccine equity. And I should mention that some of these are actually less about expanding a role and more about reducing some of the barriers that we have through legislative and policy processes. So one of these, of course, is strengthening immunization information systems to facilitate opportunistic vaccination. So as I mentioned, in the United States context, we have different states with very different immunization information systems. And that can make it hard for pharmacists to know when they're interacting with a patient, what the patient's vaccination status is. So it's really important that those systems are coordinated to promote recommending vaccines with every pharmacy contact. We also need harmonization of state laws in the US on pharmacist vaccination authority and scope. Influenza vaccination is pretty consistent across all 50 states, but for HPV and for other vaccines, there's a lot of variation in pharmacist authority and scope across states that remains to be addressed. Ongoing investment in pharmacist education in vaccine advocacy geared towards underserved groups, including racial and ethnic minorities, is also, I think, an exciting and important area for expansion. And finally, resolution of billing payment issues that can act as cost barriers. So this pertained more to the shingles vaccine, which I didn't have as much time to talk about, but addressing the policy barriers for some cost and billing issues will be an important facilitator. Oh, next slide, please. Thank you very much. I've included references here and I look forward to your questions.
That's really great. Thank you so much, Ali. I have to say that's so thought-provoking, and instantly I'm thinking that access to vaccinations is almost a proxy marker for how people will do in their life course, vaccination aside. So we're learning so much as we go, even with the questions that we've got today. So Jane and Ali, if you wouldn't mind both going live on this on your cameras, I've got a few questions I'm going to ask you. And I saw a couple of questions emerging in the Q&A box. One or two might be for FIP to answer, and I can do that, but I can hand over to Farah to read those out in between these questions. As we said right at the very beginning, I don't think it's necessarily what you tell us your opinions are on pharmacy that will become gospel, but we would love to hear what you think we can do to bridge some of these gaps. So my first question to both of you, what is the role of pharmacy vaccination now with 1, 2, 3, several vaccines on the horizon for coronavirus, also ensuring equitable access to vaccination? I've got a couple of subsequent little mini questions to ask about that, but there's something about equity, there's something about effectiveness, and there's something about affordability. And there's also something about understanding how we might deploy all of these globally. And for me, it's not just the ability to pay, but it's also the need for access as well. So I'm going to hand that to Jane to begin with, just to give Ali a moment to catch her breath. And then Ali, I'd welcome your thoughts on it as well.
Thanks very much, Catherine. I think we've got to go back to, prevention, access, equity as the 3 pillars. And what is the role of pharmacists right at this moment? In many countries, they are also responsible for testing. Countries where the pandemic seems to have taken on a life of its own, have missed the opportunity, to test, trace, isolate. And so, pharmacists are not only the communicator of messages, because messages are actually quite confusing, even within country now. I've noticed a pharmacist from Quebec, just in the chat box, saying that there is a confusing message between what the pharmacist is saying and what the doctor is saying. So clarity of message is going to be critical. Testing, another job for them to do. But let's not also forget that they have a job. Pharmacists are actually disseminating medications, at the same time. So they're doing their normal job, and another job. I think also that certainly in Canada, You know, there is a limit of, you can only have 1 month of your medication, which then means that the bandwidth of pharmacists is actually getting tighter and tighter, you know, because they don't have any more resources, but they're being asked to do more and more. So I'll stop there because I do want to give Alexandra you know, an opportunity, but then come back to talk with you a little bit about equity.
Well, that's super, Jane. Thanks so much. And I agree with you. You know, policymakers really need all the professions around the table, because there's logistics that people don't see when they receive a service. You know, we see the tip of an iceberg when we go in and receive a service. We have no idea of the impact of layering all of that on, as you've rightly said, Jane. We'll park that for a second and we'll come back to it. But Ali, your initial thoughts on this, and then we'll back and forth between the pair of you.
Sure. So I'll just echo a little bit of what Jane said about, I think it's great that you brought up the fact that pharmacists are, you know, they're managing immunization services on top of a full workload and suite of other services. And this is something that I've actually spoken to a lot of pharmacists about in the US. In the United States, the American Pharmacy Association has a great statement of the pharmacist's role as a pharmacist immunizer and what that includes, especially in terms of advocacy and messaging. But it does seem like there's a little bit, there are sort of parallel streams that's happening at the CDC level. And it's really focusing very heavily on primary care providers. And I think that maybe it might be helpful for people at the level of the CDC and people who are sort of having these other national level conversations to make sure that they're including pharmacists when they're talking about, as you mentioned, some of those messaging guidelines. You know, the CDC has some great guidance on how to provide a strong recommendation, and that includes, you know, very specific things like sharing a personal story about vaccination, saying something like, you know, my sister received this vaccine for, you know, X, Y, or Z condition. And I think that sort of harmonizing some of those messaging recommendations could play a really crucial role.
Catherine, can I just add something else? Because, you know, we're in the midst of the influenza season in the global north. And what I've noticed is pharmacists, because of certainly where I am and in other countries, you know, there are certain supply and demand issues. And so pharmacists are not only having to deal with the supply and demand issues, but the anxiety of consumers that actually cannot get that vaccine. And, you know, it comes back to the government of the day and the distribution and the infrastructure. Now, if we're dealing with this now in Canada, which is a high income country, we don't have the infrastructure sufficient enough to deal with influenza, and also the gateways. And with blocked gateways, as is pharmacists at the moment, you know, what is that going to mean to a person that runs off the street to get the COVAX because they need to get back to their job because they're the only person that's employed? So if I take equity to a global level for a minute, and thanks Gonzo for your question, you know, there are disparities in terms of the WHO target goals for immunisation. You know, we know that WHO, the goal is 90% for children and it's 75% for older people. And let me explain what happens when we get down to a country level. When it comes to the COVAX vaccine, you know, WHO has identified 3 very important high-risk groups. 1, healthcare workers. 2, older people. 3, those with underlying chronic conditions such as diabetes, lung conditions, etc. But that is a recommendation, that is a guideline. When it comes to a country level, you know, that is determined by the country, you know, the National Immunisation Technical Group. Now, in our work, the NITAGs don't have, you know, a mandatory person who is experienced in ageing and older people sitting on that NITAG. So that's why advocacy is going to need to be so much stronger. And we have to work with pharmacists, geriatricians, diabetologists to actually make the case, and in a coherent, plausible way, because otherwise, you know, the age groups for which the COVAX is going to be allocated is going to vary from one country to the next. And I note my colleague in Quebec, where it's even in, it's the age group for a high dose flu vaccine is different for Quebec as it is in Ontario. So equity is a big policy piece that FIP, you know, discusses, IFA, but it also cascades down to a country level.
I think so. And I think, you know, if you think about the, Jane, the complexities around this, nations that have federal structures beneath them are going to have a national approach, which feels very uncomfortable because this isn't how they have been working. But it has to be with equity first, because what we also have seen is that there's the age factor with outcomes from COVID, which just is exponential, isn't it? The decades that you go up. Yeah. Alongside, we have the impact in high income country of ethnic diversity alongside comorbidities. And you see these clusterings of people who may be not even at the highest age group, but middle-aged-ish, yep, who may still be working, but work in low-paid jobs, which require them to travel on public transport and live in crowded environments. And because they don't fit the age profile, they're not going to be prioritised. So it really is about countries thinking how they can manage in a global pandemic their federal response as well as their national response to get equity. And FIP needs to do this as well. We've got to have a global response with regional understanding, but then also some national guidance. I think it's something all our organisations need to stand shoulder to shoulder with, really. Ali, what are your reflections? And then we'll there's a lot of questions in the question box that really tap into this. So I think this is the theme of our responses, really. Ali. You're on mute, I'm afraid, yeah. Ali. It's the Zoom bingo, Zoom bingo. Yes. We have to have it.
Yeah, sorry about that. Yeah, I think this is a really important point about the many different sort of nested levels of authority. I nodded at this in my presentation, but this is actually something that's hard for people to understand and outside context, just how much states exert an influence on, you know, within the US, just how different things are from state to state. You know, I live in a state where pharmacists can provide the HPV vaccination, but only to people 18 years of age and up, whereas other states, it's completely different. One advantage actually about some of the national pharmacy chains being involved in COVID vaccination is that they tend to harmonize their policies across states from the get-go. So that's one potential pro. Like, you know, the larger chains like CVS and Walgreens, they will have national level policies and procedures that they set for providing a COVID vaccine, for example, but then they will still have to be working quite closely with state health departments, and then they will have to be working closely with county level health departments. It really is quite a dizzying number of levels to be working together. So that's something that, you know, here in the US as well is just quite critical.
Yeah, thank you, Ali, very much. Yeah, I think the state, the country, the way in which a nation is organised is just going to be so impactful. I'm in the UK at the moment, and there's a devolved 4-country model, and that's proving to be very difficult. Jane's mentioning messaging. There are different tiers, there's different messages, there's different restrictions, not only between the countries, but also within. At the moment, we're in a lockdown in England, so between regions, it's standardized, but beginning of December, that will start to differentiate as well. It's confusing for patients and the public, and it's confusing for the health professions who are trying to manage in an equitable way as well. My next question on this list, and then I'll ask Farah some of the questions, would be, now we've just mentioned what states need to do, or, you know, what nations need to do, but from your perspectives, both of you, have you got a real life example of one of the biggest challenges that you've seen? with ensuring equitable access for all patients to vaccination? It doesn't have to be COVID related in this instance, but what would be the biggest example, Jane, you've seen with challenge in ensuring equitable access?
Catherine, it's very difficult for me to make a poignant case when I live in Canada, you know, and you know, I'm white, I'm healthy, I have access to medical care, I have insurance, I can walk to the pharmacy, I have a mask. You know, 80% of people in Moldova don't have masks. You know, so we actually need to kind of step outside of where we are. So I can talk about the inequities of someone living in Quebec who is outside the age cohort that Quebec has decided to fund influenza. But the reality is that just down the street, we have a growing population of homeless people, right? You know, just down the road, we have a growing population of healthcare workers, you know, who are at risk every day because they don't have the right PPE. So, you know, while I think it's very important to look at inequities within country, you know, I see on the chat box, we've got people from Malaysia, you know, talking about, I hope one day pharmacists will be able to vaccinate. I go back to my comment about we're not reaching the unreachable. And I'm firmly of the belief that those that come to be vaccinated, you know, understand the importance, can get time off work, can afford it, and can wait around for an hour or 2 hours to get it. But our systems are not built for those who most need it. So are pharmacists going to have mobile clinics to go to homeless shelters? You know, a pharmacist is going to be able to work in slums. You know, that's what I see as innovation. You know, what can we do that actually launches us into a different paradigm because we know that it's the right thing to do. Public health intervention number one, vaccination. But we need to be doing something different. Because, you know, the US system is an exemplar in many ways. You know, there are chains that actually are open. You go to Japan and pharmacists are not able to vaccinate there. So there is ordinarily inequity because of the system. And so there's systemic equity as well, inequity, as well as social inequity in the conversation, because at the heart of inequity is the social determinants.
Such well-made points, Jane. I think COVID has given us all an opportunity to think differently in how we work, how we operate, and I say opportunity because you're quite right. You know, in our privileged environments, in our roles where we are protected every day, we're filled with opportunities from this. Other people aren't. They're filled with challenges and stresses and additional oppressions of their equity, if you like. So we have to think outside of the box. Ali, what's your response to Jane's challenge, which I think our whole profession, I think the chat box will start lighting up now because our whole profession does need to think outside of the box to step up to this challenge. Ali.
Sure. Yeah, I think that was a very good discussion of the social determinants and the role that plays in as a major challenge to equity. And so I'll actually talk about something a little bit different now, which I think also poses a challenge from an equity perspective, and that is supply chains. So pharmacists in the US, at least, are very well acquainted with intermittent vaccine shortages and unpredictable supply, and how that affects patients and sort of where we have some concerns. I'm actually working on a study now where I'm looking at shortages of the high dose influenza vaccine in the US and where those are clustered, and are they clustered in areas of particularly high need? Are they clustered in areas where there are a lot of older adults who would need this vaccine? And if so, what do we do about that? And I think that, you know, it's interesting in the COVID context because we're heading into a situation where we know ahead of time that there will be limited supply. And pharmacists have extensive experience handling this. I've actually heard from a lot of pharmacists that the shingles vaccine actually has also been another one where there have been a lot of intermittent shortages in the US. And if you have a vaccine where you know there are shortages or you know there will be smaller amounts, there are several things that are really important. One is making sure that you have an equitable allocation plan in place, and that you are thinking about justice concerns, health disparities, and all of those things when you are thinking about how you will allocate that initial limited supply. But then two, how are you communicating with providers and the public that plan and the fairness of that plan, and explaining to people when they will actually have access to this resource. And I think that it will just be really, really important, since this is the COVID situation is one where we know already ahead of time that there will be a limited supply and that it needs to be allocated equitably, and that providers and pharmacists need to be given the tools that they need to also communicate that plan to patients. That will just be very important.
So Ali, what you and Jane have done so brilliantly, so seamlessly together, despite being, you know, apart, is to give us this sense that we know what the nations need to do, but as professions and professionals, we need to also own some of this information. It's not enough to say how this vaccine will be distributed. We need to translate that into when will you get it? When will you be part of that solution? And I've really taken that on board. We're working out our plans for next year right now, and I know that my team member who's leading a lot of this work, Gonzalo, who's on the call, will make a note that we need to do much more about how we communicate and engage with patient groups. We do that with you, Jane, left, right and centre, but it's about how we can support our community pharmacists with this as well. Really important. Now I'm going to ask Farah, there's a couple of juicy questions in the question box. Could you select one or two of them and we can work out who can best respond to them in which order? We've been doing a Jane Ali tennis match at the moment, but there might be one or two there for FIP as well. So Farah, can you walk us through a couple of the Q's and A's?
Yes, hello everyone. We have a lot of questions actually emerging. I'll try to mention questions that are most relevant to the session. First, I'm going to merge a question from Mario and Luis, who are asking something similar to what was answered previously. How has the acceptability of pharmacy as a place for vaccination changed during the pandemic? And how can pharmacists partner with health departments and community organizations in addition to FIP and WHO to offer vaccinations in the country and alternate locations in the community? There were some comments about that. Ronald commented that Canada allows pharmacists to provide the out-of-pharmacy or the off-site vaccinations, which is a valuable service. But is this common to other countries?
I'll just, before I hand over to Jane and Ali, the fact that you've written these in the Q&A box means we can keep them and add them to our FAQs, which is part of this program, because I think every question one person asks, another person would be thinking about. But I must say that even if a practice in one country is not common in other countries, what we have learnt is that by sharing good practices and innovation, one country learns from another and picks it up and runs with it. We've seen that hugely during COVID. This has been the opportunity for our profession. I'll hand over to Jane in a second, but I just wanted to say, colleagues, that on our website since March, we've been sharing examples of how pharmacy has supported patients with COVID, societies during COVID, and how it's remained open. Jane made a huge thank you to the profession, but the acceptability of health information, as well as supply of medicines, but health information through community pharmacies has shot through the roof in the past 8 to 9 months. And if ever our profession felt shy or perhaps not necessarily well understood, we have been in the past few months. So we need to carry on that crest of a wave and not lose our confidence about the fact that many communities find pharmacy and pharmacists the access point for healthcare, not just for themselves, but for their family. Jane, your reflection on those questions that Farah's laid at your feet.
Yeah, look, thank you. The question was, how has it changed? It's changed in a number of ways. you know, what I see and hear is that, you know, the bandwidth, you know, is stretched because they're doing their job and they're doing, you know, the testing and the potential consideration for the vaccine. I think also that, you know, what I'm seeing, and it comes back to how can we do things differently, Catherine. I do wonder about communication. We now have perspex, we wear masks. Are pharmacists comfortable in the tips and tricks about communication with masks on? Because I think that's an important area of education that we all need to do. I think also that because many GP practices are online now, you know, the person that a consumer can best talk to is that pharmacist. And so they're actually getting probably more complicated questions about diagnosis and symptoms because the GP is less accessible in terms of a face-to-face conversation. And I do think that there was another part of the question, that how can we be part of a discussion about the health department? And it's the trickle effect, isn't it? Every opportunity, be at the front door. Every opportunity, send the note, make the contact, you know, and it's the squeaky wheel, isn't it? All the time. And when there's an opportunity, stand in and make a comment. And then, because what they're looking for is trusted relationships. The world goes round with trusted relationships. So I would encourage that person and all pharmacists, you know, to see the opportunities of talking with government and non-government all the time as part of their relationship building and influencing policy.
That's superb. Colleagues, the whole profession need to stay squeaky. That's what Jane is telling us to do. And I agree with you. Squeaky wheels get the oil, Jane. It's a known tactic. I just wanted to, before I go to you, Ali, for your response, I just wanted to make sure everybody's aware that Gonzalo has put in the answer box that Ireland has recently approved off-site vaccination by pharmacists, including nursing homes, schools and workplaces. And we shouldn't just view this as an Ireland solution only. We should view this as a model that we can all learn from. So let's take these as little nuggets that we can share, and we will do that at FIP, definitely. Ali, your reflections on this?
Sure. So I'll address a little bit this question of the acceptability of pharmacies as places for vaccination and how has this changed or not changed during the pandemic. So it's quite interesting. In one of the literature reviews that I did prior to this, I think a lot of the sort of scaling up of pharmacy vaccination in the US was sort of catalyzed by the 2009 H1N1 pandemic, where we did have finite doses of an influenza vaccine. And it became clear that certain communities weren't being reached actually during that vaccination campaign. And that was one of many things that prompted sort of the scaling up of pharmacy vaccination. And much has changed since then. And I actually think that there's room to do a lot more formal research on this, because the acceptability evidence that we have for influenza vaccine, for pneumococcal vaccines in the time since then indicates that pharmacies really are quite acceptable sites for vaccination for many people. Really, the trick is, I think, ensuring supply, ensuring messaging, streamlined messaging. And I think that right now, you know, it's interesting because we have a lot of evidence that people in the US have been avoiding primary care appointments during COVID, but pharmacies have remained open and busy. And I actually think that those right now especially might be much higher volume sites for patient contact and makes them really, really good sites for health information communication about COVID. I know even anecdotally, I've seen like my community pharmacy, which I have been to, has all kinds of signs up with health information about COVID. They're just really, really good sites that I think the density issue, I think, is even bigger now than it was before COVID, because people are still continuing to go to pharmacies, yet they're maybe not continuing to go to their primary care practices right now and being told to wait on some of that. So I think it's especially critical right now to make sure that pharmacies have the tools, the time that they need to be communicating up-to-date information about a COVID vaccine. You know, it's interesting, the pharmacy near me has a lot of preliminary information about COVID vaccination. They're saying, you know, we don't have one yet, we'll have one, we don't know when, but here are the things you can know in the meantime. Here's a hotline you can call if you want to ask questions about that. You know, it's all sort of in place already, which is great.
It's amazing, isn't it? And what we get asked for at FIP very often is some emerging responses, not the definitive answers. Over the last few months, we've really changed as a profession, I think. Both Ali and Jane, you need to know that pharmacists are quite risk averse, and we don't like giving holding statements if we can avoid it. We like to have definitive answers. But the COVID situation and emerging evidence around all sorts of things means the profession has had to change. And what pharmacists want is to be able to tell patients not just the right answer, but when they will have the right answer. So we can help with that. And those examples are just superb. Farah, what other questions are hot in the question box for us?
There's one question, I think that is addressed for FIP. Can the FIP engage pharmaceutical industries like Pfizer to include pharmacists in vaccination trials, especially for COVID-19, as this is a good opportunity for pharmacists to take up?
So I think that could be a definite yes. As you know, that this whole program has been sponsored by Pfizer, and they're very, very interested to support pharmacists, as are all our other partners, to support pharmacists and pharmacies as being places and people who can either provide vaccination services or provide vaccinations themselves. So I'm certain we really want to work as a united front around all of these areas, you know, to work with our partners like IFA to think about how we might tackle inequities to do with age and the complexities therein, to work with our corporate partners so that they understand the role we can play in this as a solution, not protectionist, but really open-armed. And then Ali, with colleagues like you who can bring us along the pathway with the data that's emerging, but also the good practices. And I think, Farah, our colleagues on the Q&As need to know that we will do everything we can to ensure that message is joined up. And also send us in examples of how we can do it, because, you know, we need all the ideas we can possibly get. What else, Farah, have you got in the Q&As? And we'll pass it on to Jane and Lee.
Okay, we have this concern that is addressing vaccines hesitancy and its role in the delay of proper care, especially in immunization. Especially that there's an issue of some patients who are focused on feeding follow-ups because of the fear of COVID-19, like cancer patients. So what are your thoughts on that?
So I'm going to go to Ali first on this one, because Ali, you mentioned about different groups may have different belief systems about how to access vaccines, and lots of mythology can arise, but the reasons for those myths may well be well-founded. We can't dispel them. What would be your thought on that question?
Right. Vaccine hesitancy is really interesting because it really requires involvement from a lot of different stakeholders to address. So it requires that, you know, there's one paper I read that talked about the immunization neighborhood, which includes primary care providers, pharmacists, public health departments. It really includes every stakeholder who has some role in immunization. And I think addressing vaccine hesitancy is really something that all of those stakeholders have a role in addressing. And one of the things that we do know in the US, there's so much literature on vaccine hesitancy, but one thing that emerges time and time again is that a recommendation for a vaccine from a trusted healthcare provider is hugely influential in people's decisions on whether or not to get vaccinated. And so I think that, again, you know, reaching out to different stakeholders and making sure that they are sort of harmonized on practices that they use for doing that would be really helpful. I know that it looks like people have mentioned in the comments sort of different messaging coming from different places. And I think right now it's especially critical to make sure that people have the same messaging on that and have a harmonized message. And it's really nice. So the CDC, actually for the HPV vaccine specifically, has very specific suggested language that it recommends in talking to patients and their families about the HPV vaccine. It's almost like sample scripts that you can use when you're talking to people and addressing concerns. And I think that things like that, it's like a one-page document that can be used by any provider. And I think tools like that are really, really helpful because they just provide a very, very clear set of messaging best practices that can be used in different sectors to address hesitancy.
As ever, Ali, that's just great advice. I think it's that mindset, Jane, that you mentioned about for people who don't access vaccinations or healthcare, full stop, we can't expect them to come to us because they have never come to us. We've got to be able to find ways to go to them. And when you're seen to be stepping out, then you're seen to be moving into developing a trusted relationship. What would you respond to that with, Jane?
Do you know, it really is. We come to vaccine hesitancy and safety from a personal and a societal perspective, don't we? You know, there's some great work in Greece, you know, that, you know, the family responsibility has been to be vaccinated. So there's a cultural sort of frame of reference to this as well. A great anecdote is from Western Australia, where a series of residential care facilities encourage their employees to be vaccinated against flu. And just this year, it's been 100% of employees in these facilities that have been vaccinated. But a couple of years ago, there was a group of employees that refused, and you know, the employer couldn't work out why, until one of the employees said, "What would you expect? My friends and colleagues come from South Africa, and we're concerned about HIV and needles." And so there was a cultural overlay that they needed to address. And so now for certain employees, they don't have needles, they have patches. So I think we've got to come to this whole issue of vaccine hesitancy, you know, not from a macro, but really looking at local situations. I always go back to, we listen to the scientists, nobody else, it's the scientists, because they're really at the front line of understanding the epidemiology and also the efficacy of these vaccines. I do believe that websites and web portals such as the Vaccine Safety Net, WHO Vaccine Safety Net, and IFA has just become verified as a member of that, are going to be important portals to seek information. And of course, a common message, you know, are we at the time, Catherine, when FIP, IFA and others, you know, IDF, NCD Alliance, can actually make a statement together? You know, so it's about joining the dots and being clear, you know, about the safety and the efficacy of current and future vaccines. That's going to be helpful. And then very much at a local level, you know, what are we communicating? And if we don't know the answer, be prepared to say, I don't have that answer, but I'll get back to you. Very important.
Yes, and that fits very nicely with a lot of the themes that both of you have been saying. You need a macro approach, and you need to be talking about standards and equity on a macro approach. But when it comes to beliefs that can affect individual actions, you have to go individual by individual. And probably we all need to turn the volume down on whether people believe in vaccines or don't. We need to find out why they don't, and if we can help them with that. So that we are doing our bit to ensure equity. Jane, I think that's another gauntlet you've thrown to us, which I happily pick up, which is let's do some collaborative messaging around this. There is power and amplification in joining your voices with others. Fabulous. Farah, I'm being super greedy. We've got time for one more, or maybe a little clutch of them. And then if you read us out a clutch of them, then Ali and Jane can pick the one they'd like to answer. And then I'm going to wrap up and present the next event, which will be this week.
Okay, we have this question, which was repeated in different ways. How can FIP and WHO provide more health information and clarity to rural population in developing countries like Nigeria, where some local communities still have strong belief that vaccines are of no use and have negative consequences when taken? This is one question. You want me to continue with other options?
I think let's have a little range of them, and then Jane and Ali can answer whichever ones they want to, and we can also refer back to previous answers as well. Thank you.
Okay, so there was a case worth mentioning that most patients and pharmacists are focused on vaccinating flu rather than promoting multiple vaccinations during COVID-19. Will this lead to the delay of proper care using immunization and vaccination?
Just one more, Farah, and then I think we've got a whole range of questions on particular areas to do with vaccinations.
What do you think about some regulation in some countries that pharmacists are still not allowed to give vaccinations to the patients?
Perfect. So, Ali, going to go to you to pick one or two of those to give us quite a speedy response. Then I'll go to Jane, and then I'll answer any that were particularly about FIP and before we close. Thanks, Ali.
Sure. So I'll conclude by addressing the question about trust and beliefs in vaccines and sort of mistrust. So as I mentioned before, just to kind of tie all these points together, it's just so important to do formative work and especially qualitative work to determine the reasons for that mistrust, which is something that, you know, we've done some of in the US, and that actually informed HPV vaccine messaging. So people did work on why people were reluctant or hesitant, and that informed the CDC sample language that they put together. And I just think that kind of work is so important in putting together messaging that really directs those causes of mistrust.
It builds on what we were just saying, isn't it? It's about going right to the individual to understand it a little bit more. Jane?
Mm-hmm. Yeah, I'll just respond to the question about regulations and regulatory frameworks. And what I would encourage each of those people who said in the chat box, we can't vaccinate in our country. You know, every time we open our mouth and speak, we are advocating. And be clear about the common goal. The common goal is that you want to be that profession that is enabled to vaccinate because you believe in it, because it will save lives. So every single time you open your mouth, whether it's to a consumer, whether it's to a doctor, whether it's to a government officer, you are advocating for the rights of people who choose to be vaccinated, and we applaud you. So thank you.
That's a wonderful message, Jane. That really helps each individual who's part of a call like this to feel like they can play their part, as well as being part of a national organisation and an international federation. It's sometimes difficult, isn't it, during these times to work out what can you purposefully do, but you're quite right. In this instant, we're all members of this global community, and how we behave with our masks and our hand washing and our spaces and, you know, the lockdown rules, that's important, but advocacy should not be disregarded at all. Well, I think you two have just responded to the questions that were raised there. There's a lot that FIP has and will continue to do. I would urge each colleague that is on the call today with an issue about their own country to have a look at Series 3, where they can engage with a regional event that will address some of the countries that may be of relevance to them. Because that could be really, really practical. But please read, colleagues, the answers to the Q's and A's and the chat box here. And please join me in thanking our superb panelists, Ali and Jane, today. I have to say, both of you, this felt very much like you'd rehearsed this. It was so seamless and wonderful, and you both fed off each other's answers just beautifully. So my excitement by being part of this discussion is that you flowed so really well together. So please join me, colleagues, in silent hand clapping for Jane and Ali, and we look forward to having you back many times hence. Thanks
very much, Catherine.
You're super welcome. Thank you both. Absolute delight. So Farah, would you mind moving us on? Lovely. I'd just like to say, colleagues, I know that you can all take a moment to thank you to Ali and Jane, and they well deserve it. Really, they've worked so hard for us today, and it's been a wonderful discussion. But we're never going to stop welcoming you to the next event, and the next event is on the 18th of November, which of course we find is tomorrow at the same time, 2 o'clock Central European time. The episode is Pharmacists, Vaccinators and Patient Safety. It's an interview format that focuses on the development goal number 19, patient safety, from the perspective of vaccination by pharmacists. There we will be discussing the role of pharmacists in delivering safe vaccinations. So today it was about equity and access. Tomorrow it'll be about safety first. Participation in monitoring and adverse event reporting, the role of improving vaccination rates, which again feeds so beautifully into today's session. So we would welcome you all in attendance there. Next slide, please. And it really falls to me to again sincerely thank our speakers. It's been an absolute delight, as ever, Jane, and a wonderful pleasure, Ali, to work with you today. The recording of this episode will be made available on www.fip.org and on our Transforming Vaccination website too. Please give us your feedback at webinars@fip.org so we can continue to modify, improve and enhance all of these digital offerings. Today's energy has been marvellous. Thanks to Ali and Jane for that, and thanks to Farah and to the whole team for the support and organising. Thank you for attending. Thank you for your questions and your comments. And as ever, thank you so much for your support for FIP. Good day to you all. Goodbye.